Hey everyone, in this lesson I'm going to be talking to you guys about polycystic ovary syndrome, what it is, what are some of the causes of this syndrome, what are some diseases that are highly associated with polycystic ovary syndrome, and then finally I'm going to talk to you guys about some treatment methods to help alleviate some symptoms of polycystic ovary syndrome. So to begin, what is polycystic ovary syndrome? Well, as the name suggests, it involves polycystic ovaries, so ovaries with multiple cysts. And you can actually see this on an ultrasound of a patient's ovaries. You can actually see these like black little holes. It looks like black holes. They're actually cysts within the ovary. So what are some of the characteristics or what are some of the symptoms of the syndrome? Well, one of the main ones is menstrual irregularity. And this irregularity can happen as soon as the patient actually enters puberty. So a lot of times these patients will have a delayed onset of menarche or a delayed onset of their first period. So they have their first period a little bit later or a little bit older than average. They also can have oligomenorrhea, which is just having less than 9 menstrual periods per year. So they have less menstrual periods during their adulthood. And sometimes they can even have amenorrhea, which is no menstrual periods at all. So they just go throughout their life without having any periods whatsoever. But interestingly enough, they can have a regular, what I call regularization after the age of 40. And what I mean by that is they often have a lot of these symptoms, such as oligomenorrhea or amenorrhea, can actually kind of normalize after the age of 40. So after 40 years of age, they can kind of have more regular periods. And another main characteristic of polycystic ovary syndrome is hyperandrogenism. And this is kind of one of the big ones, kind of one of the big characteristics that cause a lot of the visible symptoms that you see with these patients. The first one is acne. Acne is very common in patients with polycystic ovary syndrome because of the high levels of androgens. Another one is hirsutism. Now, hirsutism is actually just a growth of hair. So these patients oftentimes will grow or have more terminal hair growth. So you get this kind of darker hair growing, particularly on their face or on other parts of their body. And then again, another one is actually hair loss. So it's almost a kind of a male pattern hair loss due to high levels of androgens. Now, what is the incidence of this syndrome? Well, the incidence is quite alarming. It's actually one of the most common endocrinopathies in women, and typically about 6.5 to 8% of women are affected with this syndrome. So what are some of the medical conditions that are highly associated with polycystic ovary syndrome? Well, first off, approximately 40 to 85% of women with polycystic ovary syndrome are overweight or obese. So there's oftentimes a connection between BMI and polycystic ovary syndrome. So this leads us to a list of conditions that are associated with overweight and obesity itself, such as type 2 diabetes. So women with polycystic ovary syndrome typically have an increased risk of type 2 diabetes. Again, this follows in line with glucose intolerance and insulin resistance. They also are dyslipidemic, which again follows insulin resistance. And because they are at a higher risk of being overweight or obese, they have a higher risk of having obstructive sleep apnea. Another condition that's very associated with insulin resistance and obesity is non-alcoholic fatty liver disease. And women with polycystic ovary syndrome have a higher incidence of non-alcoholic fatty liver disease. And you can see here that on the left, that says a normal liver on the left, but on the right is a fatty liver, and you can see there's a lot of lipid droplets within the liver there. Again, a lot of these women also suffer from depression and anxiety. And because, as I mentioned before, they have menstrual irregularity, they can often have an anovulatory infertility. So if you're amenorrheic, you typically have something known as anovulatory infertility. So they actually don't ovulate properly, and they become infertile as a result. Another one is endometrial hyperplasia. Now, endometrial hyperplasia is just an overgrowth or excessive growth of the endometrium within the uterus. And now this also leads to an increased risk of endometrial cancer because of the hyperplasia. Now, moving on to some of the etiology and pathogenesis of polycystic ovary syndrome. To begin, the etiology is unclear. It hasn't really been elucidated at present. However, although the etiology is unclear, it is known that certain individuals are at a higher risk of polycystic ovary syndrome. Individuals, who are obese are typically at a higher risk of polycystic ovary syndrome, as I mentioned before. Those that are insulin resistant are at a higher risk of polycystic ovary syndrome. Type 1 and type 2 gestational diabetic moms are also at a higher risk for polycystic ovary syndrome. Another one is premature adrenarche. Now, adrenarche is the start or the commencement of the adrenal glands to produce androgens. So during childhood, people typically produce some amounts of androgens, very low amounts, particularly low amounts, but individuals that have a premature adrenarche seem to be at a high risk of polycystic ovary syndrome. Also, people with first-degree relatives that have polycystic ovary syndrome are at a higher risk of getting it themselves. And now this lends credence to possible genetic influences. So a lot of these may be the cause of polycystic ovary syndrome or may be the result. It's still not known for sure, but again, the first-degree relatives seem to show that there is some genetic influence with regards to polycystic ovary syndrome. And that kind of leads into the pathogenesis. And indeed, there have been multiple studies showing that there is some genetic trait involved. And there does appear to be environmental factors that influence the onset or the phenotype of the polycystic ovary syndrome. Some studies have shown that perhaps there's certain genes on chromosome 2 or chromosome 9. And here's a handful of different genes or proteins that may be involved in polycystic ovary syndrome. One is luteinizing hormone receptor. Another one is human chorionic gonadotropin receptor. Another one is called FATA. Another one is androgen receptor. Another one is sex hormone binding globulin. Another one is DEN-MAD, domain containing protein 1A. And the last one, again, is insulin. So there still could be some issue with insulin or insulin signaling that's predisposing individuals for polycystic ovary syndrome. And in fact, as most of the associated risks involved with polycystic ovary syndrome show, is that a lot of them seem to have insulin involved, such as insulin resistance and obesity and different types of diabetes. And another important thing is that insulin is actually an activator of thecal cell production of androgens. So thecal cells are the cells that actually surround a developing follicle within an ovary, and insulin actually stimulates the thecal cells to release androgens. So again, that's another possible mechanism by which polycystic ovary syndrome causes hyperandrogenism. So now that we know some of the symptoms and some of the risks and some of the diseases associated with polycystic ovary syndrome, what are some of the treatments we can give to these patients? Well, one of the first things we like to focus on are some lifestyle changes, because as I mentioned before, a large amount of patients with this syndrome are overweight or obese. So we like to try to change some of those parameters. So we like to get them on a diet or exercise, just to try to try to reduce their BMI, try to reduce their weight, and to try to normalize their insulin tolerance and glucose tolerance. There's also some pharmacologic treatments as well, and this is particularly important for stabilizing the menstrual irregularity. So some of these combined estrogen progestin contraceptives are very effective. Oral contraceptives can treat not only the menstrual irregularity but also hyperandrogenism. Something else that's important is medroxyprogesterone acetate, and you can give these to patients, and this is very important for treating and for protecting these patients against any endometrial cancer, as I mentioned before. This is not maybe not treating the hyperandrogenism directly, but it treats or protects the endometrium from any hyperplasia or cancer. Metformin, again, is a regulator of insulin signaling, and this has been shown to help a little bit with the polycystic ovary syndrome symptoms. Now, for patients that have are not getting the effect that they want, they're not seeing the changes that they want. Maybe they still have hirsutism or bad acne. You can give these patients anti-androgens such as spironolactone and finasteride. These two drugs can act to inhibit androgen influence and treat some of those hyperandrogenism symptoms such as acne and hirsutism. And another set of pharmacologics is the gonadotropin-releasing hormone agonists, and that can help stabilize the menstrual cycle as well. Anyways, guys, that was a brief lesson on polycystic ovary syndrome. I hope you found it helpful, and thank you so much for watching, and have a great day.